Hey, I'm Dr. Craig Chappell at Intuit Medical, and we've made a couple videos about carpal tunnel, but I've never really covered one of the conservative options for treatment of carpal tunnel syndrome, and that is a cortisone injection. And I just want to go over a little bit of anatomy with people because there's some misunderstandings on how we do this. But before we used imaging to guide some of these injections and put injections where we want them, it was all done on palpation-based ways of doing things. And so I want to demonstrate on this patient, but could you do this for me? So this little ridge right here represents the palmaris longus tendon. The palmaris longus blends into the palmar aponeurosis, and which kind of blends into the transverse carpal ligament. That's what we cut during a carpal tunnel release. However, what I want to demonstrate in this patient is if you look at this ridge, historically speaking, with a palpation-based procedure, what we would do is just place the needle ulnar or towards the little finger of that tendon and inject towards the ring finger. And I want to show you kind of a unique situation here. So we're looking at palmaris longus tendon on ultrasound, and I just want to demonstrate a couple, I don't know if dangers is the right word for it or not, but I'm going to show you some pictures on the ultrasound. So what we're looking at here is the median nerve. And this is radial over here, it's a radial artery, and it's ulnar on the right side of the screen. I know it's the median nerve just because of its appearance. I can rock the probe back and forth, and I see these tendons light up, so these are the flexor tendons that go to the fingers. This is the median nerve, and right above it is the palmaris longus tendon. Let me kind of waggle that back and forth so you can see it really good. Palmaris longus tendon. This is flexor carpi radialis over here. It sometimes looks like median nerve, but you can see that the transverse carpal ligament going over the top. This is inside the carpal tunnel. This is outside, so that has to be a tendon. This is the nerve. But what I want to demonstrate as I go towards the palm, you see palmaris longus slide radially. So if we were to do a palpation-based injection on this patient, we are going to go right off the edge of the palmaris longus, right through the median nerve. So that's what we're trying to avoid with imaging. And it's interesting, like how many times this has been done in the world and how little damage has been done, but occasionally there probably has. So it's kind of cool that the body is so forgiving like that. However, my belief is if you can miss it, miss it. And the patient will like it as well. They won't feel like their fingers just got electrocuted. But anyways, that was just a kind of a demo of why ultrasound may be helpful at doing some of these injections. So the next thing we're going to do, in this patient, she has mild carpal tunnel symptoms, so we're going to do a conservative option. We've tried splinting at night, some exercises, some physical therapy, and now we're going to do what's called a cortisone injection, or referred to as a cortisone injection, even though we very rarely inject cortisone, if ever. In my experience, I've never injected cortisone, but we use other medications, other steroid medications. In this case, we'll use celestone or betamethasone. The next step is we're going to kind of line this up and do an injection in around this nerve. And what I want to demonstrate is it appears that the efficacy or how well an injection works is related to where you put the injection. So if we can get it around the nerve, it should theoretically work better than if we get it kind of in the area. So we'll demonstrate how to do that. When you're doing these injections, obviously you want to do sterile. We use a sterile probe cover, sterile gel. As far as anatomy goes, I'll point out some anatomy structure we don't want to hit. So this is the ulnar artery here, ulnar nerve next to it. This is our median nerve. This bone represents the lunate. This is the entrance of the carpal tunnel. So this is where we want to put our injection. If we go a little bit distal, you can see the transverse carpal ligament coming over. Once again, ulnar artery, ulnar nerve, and our injection should come down right through here. And we're going to float the median nerve up off the flexor tendons and off the transverse carpal ligament. A lot of people, especially practitioners, don't know which side of the median nerve to inject on. Sometimes it seems easier to come from the radial side. This is the radial artery. This is the flexor carpi radialis. This is the median nerve. So it seems like you have a pretty clear shot to the median nerve if you're doing an injection in this direction. I would argue that's not the best way to do it, and this is why. I still like the ulnar approach. So in this case, we have the ulnar artery down here, median nerve here, flexor tendons here. Could you wiggle your fingers for us? Flexor tendons moving the median nerve around, and we have a pretty clear shot here. And this is the reason I would pick the ulnar approach over the radial approach. So if I follow the median nerve up the forearm, so I see the median nerve really well right here, we're going to go a little bit higher up, median nerve. Now we're going to go distally towards the hand. I want you to watch this little black dot right there at the tip of the arrow. It comes off, and it will travel up alongside the flexor carpi radialis right here. And so that little thing is a nerve branch off the median nerve. That nerve innervates the skin on the palmar thumb. So it's basically the skin overlying the base of your thumb is where that goes. If you inject from the radial side, you have a higher likelihood of hitting that, especially the farther down in the hand you go, because you'll see that little black dot separate from the median nerve and travel with this tendon, and it goes up into the skin right here. You don't want to hit that when you come in and inject around the nerve. So taking a ulnar approach when you do the injection seems to be the safest approach in this method. If for some reason you started your injection way down low, like in the palm of the hand, which pretty much never happens, another reason to take the ulnar approach is if we get down far enough into the hand, here's the median nerve here, and we keep going down just a little bit further, and you'll see a nerve pop out, right? It's basically this black shadow right here is the thenar motor branch, but you should be, people shouldn't be injecting in that area, but that's another reason to go ulnar versus radial if you're considering this injection. If you do the sterile, you can kind of put your needles where you need to get them without risk of crowding your probe or those types of things. So the first thing we're going to do is a numbing injection just to make the injection more comfortable. This is going to be a little pinch and a burn. Here we go. And with this injection, you can actually kind of build a standoff underneath the skin, and it does burn, but it flattens out the skin so your probe can see the nerve a little bit better, so you're not fighting the curve of the wrist with a linear probe. And the next step is we're going to put the needle in, hopefully just deep to the the median nerve, just deep to it, and then we'll go superficial to it. And once again, we want to make sure the ulnar artery's out of the way, ulnar nerve's out of the way, so we're way out of the way on those two structures. We're just at the entrance of the carpal tunnel. So the next part is we're going to inject right around that nerve. So this is a large volume injection with a steroid in it and a little bit of a numbing agent. So the patient can get a little bit of numbness into their fingers for a couple hours following the procedure. Usually doesn't last too long, but we'll go ahead and start that procedure. And we're going to inject in. We're going to follow our needle down. We're going to follow it, find it really quickly because it's a rather steep injection. And we're going to see the median nerve. We get right next to it, not in it. So that's the goal here. There we go. And we're starting to peel off the bottom layer of the nerve from the flexor tendons. And we'll go a little bit steeper, see if we can get our needle right in the corner. Perfect. And we're going to see if we can get it off those tendons. All right, follow the needle in. You always want to see your needle tip where it's landing. There we go. So we basically freed up the nerve from the flexor tendons underneath. And our next step will be, and like I said, this is called a hydrodissection or a neurolysis. So we're just freeing up that nerve with a large volume with a little bit of steroid. And we're going to go in next and peel it off from the transverse carpal ligament and follow it all the way around. Good. All right. And so that feels like a lot of pressure. It usually is not terribly painful to the patient. And we're going to leave it right there for now. And the needle back. And now what I want to show you is median nerve is now here, surrounded by fluid all the way up into the forearm. So we definitely covered the carpal tunnel, and then we slide down and you can see that the fluid now is tracking all the way down into the palm. This right here is the transverse carpal ligament. So we are well into the carpal tunnel after this procedure. So the nerve is now floating back and forth through that area. And with a little bit of steroid in it, we may be able to shrink that nerve down. In this case, this nerve measured about 10 millimeters squared. So it's the upper end of normal, which correlates with mild symptoms. So we expect a pretty good result from this injection. But once again, it appears that if we can actually get it in the right spot, it works a little bit better. And we avoid hitting what we don't want to hit.